Thank you for having me this morning. I'd like to thank Dr. Sandbar for his courtesy in helping me prepare my slides, and also to Deborah Bruce, the director of our state association, or our state board, who asked me to do this talk this morning. I think on behalf of the OA, we're pleased and proud to partner with the allopathic side of the house on this problem, and just thank you. I made this slide thinking about the weather we had a year ago last year when it was about 20 degrees, and I took this from the back door of my room at the Jamaica Hotel where we had our CME event in November and stuff. So I thought it'd be a great slide for the weather today, but you know, the weather's changed on us. So these are the materials that it was requested that I would talk about today: monitoring and follow-up, especially from a primary care standpoint. I think in primary care we end up with kind of the sickest of the sick, the people that have the fewest amount of resources. There are a lot of great things that could be done for patients, but if they're uninsured and are out of work, you know, that could be a very complicated patient for us to address. I think part of monitoring progress is trying to take a complex psychosocial problem and put a measurement on it so you can measure how well you're doing. We use verbal scales, numeric scales. You can use other measures of function. Pain intensity scales. The Wong-Baker scale is probably one of the more popular ones. I keep this on the wall in my office and all of our exam rooms, and I find that I use it repeatedly, even for you know, other problems, infections and things. Asking people how they try to hang a number on it. You know, that's one of the things we use in coding. And I think the Wong scale is nice. You can also use a nonverbal indicator scale. It's nice for nursing home patients or maybe people that are really at the end of life in a palliative care standpoint if you're looking to quantify those symptoms. We like to try to document and talk to the patient about functional goals. Really, we're trying to get beyond activities of daily living and make these people functional. Hopefully, they'll be able to hold down a job or at least get things done around the house that they require. And you know, in the slides there, we have an employed fireman, somebody who's able to play. And a lot of these patients really are not going back to work in their original capacity, and so they really need to be encouraged to be getting back into some type of educational activity that meets their new functional ability. I think from a physician standpoint, the first thing you need to do is decide how often you're going to be seeing these patients. You need to stay on guard for common problems and always be asking about side effects. Always in the back of my mind, I keep Title 510 in my mind. That is the responsible prescribing of opiates statute for osteopathic physicians. And then USC 21 is the federal rules. And if you haven't read those, they're good to look up. I think you should always be revisiting your diagnosis on these patients. I mean, you hate to be treating a metastatic L5 when you think it's just a bad disc. And so if they're not responding, I think like Dr. Anthony mentioned, you really need to be going back to your differential. And you need to be honest with your patients. I tell a lot of mine that I really don't care about their pain, at least not the way they do. They're the ones that are experiencing it. I care as their physician, and I want them to be functional. But I tell my patients I really am not looking to get you to a pain level of 0 because it's not going to happen, and you shouldn't expect that either. And I don't mean that in a snide way, but in an honest way, because really no one cares like they do. I always try to make sure that the things I do in my practice I can explain to 12 people, and part of that involves using the universal precautions for pain medicine. This was described by Gorley in 2005, where they try to take principles from infectious disease in this case and apply an orderly approach to addressing pain patients. And you know, part of that is to come up with an appropriate differential, like the previous speakers have said, do a psychosocial assessment, talk about function, a trial of opiates. I like to start with a 2-week trial of opiates. When I start an opiate in patients, I think, and a lot of people have problems are going to happen. They happen early. I think it's a good opportunity for us to see if the patient is going to follow their directions. If you give them 14 days of medicine and they're back in 7 and they've used it all, I think that's a harbinger that things aren't going to go well for you. With your relationship, I tell all my patients that it's, urine toxicology screens, UDTs are going to happen, and that doesn't mean that I suspect them of anything wrong. It's just that we need to document that, and I say, I need to know what's in your body. Then always keep detailed documentation as well. This is Title 510. I may have made a mistake on that. It should be, it's either 5.9 or 5.7-2. So I apologize for that. But these are the things that are required by DOs who engage in treatment of chronic pain. If you'll notice one of them in there on item 5 is a consultation with an addiction specialist if things are going wrong. I kind of got interested in talking about pain management as a trustee of the OA, which is really an advocacy board for physicians in the profession. And we're seeing a lot of rural primary care types get in trouble with our board for having, quote, sloppy records. And I saw some of the records and they looked appropriate from a clinical standpoint on how to take care of people, but there are certain things that you really need to document to keep yourself in compliance with the law, and you'll do very well taking care of your patients not documenting some of those things. But if you ever get scrutinized, it's pretty much a checkbox type issue, and you want to make sure that you're following the letter. As far as monitoring adherence, I'm kind of new to the current opioid misuse measure. I've been trying to figure out how that's going to fit in my practice. I've used it a few times. The nice thing about it is that they're kind of sneaky questions. They're questions that don't really sound as much like, they're trying to lead the patient into talking about their opioids specifically. They ask questions like, how many times in the last 30 days have you been angry? How many times have you had to use your medicine other than prescribed? Have you ended up in the emergency room and such? Urine toxicology tests are important. Those can be done in your lab, in your office now. There are CLIA-waived tests available that we'll talk about in a second, versus sending them to the laboratory. I started doing them in my office because cost was a barrier to a lot of these patients in doing urine drug testing. I had one patient that got a $700 bill from the lab for a UDT that I sent out, and you just can't do that to people. The prescription monitoring program is an invaluable tool to use. I think yesterday at our board meeting we were talking about did your board put together an emergency rule here recently that's going to require a P&P consult with each prescription? Is that true? I think that...
yes, it is true.
Yeah. Our board voted not to support that for our people, thinking that is another requirement, but I think that'll be before the legislature for consideration soon. I also like to ask family members, especially if a family member comes, just a random question. Hey, how's he doing? Is he taking his medicine right? Are you concerned? Is there anything going on? Because, if anything does happen unfortunate, they're going to be the ones that are going to be upset with you, and it's nice to say, hey, I asked you how things were going with your husband, and you said everything was fine. And I think that could be helpful. Pill counts, I do it on occasion. It takes a lot of time. It's frustrating. It's good to have the patient back, in 2 weeks and say we're going to count all your medicine, but it does take a lot of time. And I think pill counts were in your rule too, right? Yeah. Oops. Okay, and this is a slide on the COM. The nice thing, as Dr. Weinecke said earlier, is that it helps identify patients who you are treating now who are currently misusing their medication versus the other ones which predict who might misuse their medication. And those are the questions on all my slides. I put the links where they came, so if you want to look on the CD, you can see where the actual forms came. Urine drug testing, you have a 1 to 3 day window for most medications that we're going to be prescribing. It's a class-specific immunoassay. There are lots of false positives that you have to be on guard for. If I get an unexpected result, I always send it to the lab for confirmation, especially if it's going to change therapy, like make me want to discontinue the medications or refer. There are CLIA-waived tests available. This is a real test from my office, and I like this CLIA-waived website. You can buy tests there for about $2 in quantity. CMS, last I looked, was reimbursing around $20. That's what we charge cash patients for it, so it's not a barrier to care. And commercial has paid quite a bit more for it. It works differently than a urine pregnancy test. You lose your luminescence when the test is positive here. So you can see this patient is positive for opiates, benzos, and OxyContin. And the first time I ran this test, my nurse came running in, doctor, he's on everything. And it was a totally negative test and everything. So who, when, and why? This is a great article on urine drug testing in clinical practice. You can find that on the web. It's a great read. I use it mostly just like they say. Number one is to advocate for your patient and prove that they're a legitimate patient and legitimate user of their medication. Who? You want to do that on your new patients who are already receiving a controlled drug, patients moving into the area or have been dismissed or ended their relationship with someone else. And when you're thinking about making major changes in treatment, like Dr. Anthony said earlier, things aren't going right. I think it's time to be very inquisitive as to what's going on with your patient. Just talking with doctors about random drug testing can be a very adversarial, uncomfortable time for you and the patient. We instituted a random drug testing program in our office with a die. And so I just hand the patient the dice and roll it. If it came up a 1, it was time to go get a sample. And we had everybody roll the dice, and it was totally random, and everyone did it, and it worked great. And since I've done that, that kind of broke the ice on getting the program going, and I haven't had anyone refuse a sample since we started doing that. Other ways to do it are you can do it in consecutive blocks. If you want to have a program, you can order 50 tests and do the next 50 patients. And of course, you want to do it after you see some aberrant behavior. Before I get a urine test, a couple things I like to know. I like to ask the patient, when did you take your last dose of medication? And they'll say, this morning or yesterday or something like that. If you don't ask that question, you're going to come back with a negative result, and they're going to say, well, I haven't taken it in a week, and then what you do. So I like to know that right off the bat. And I also like to know if they're in withdrawal. And there's another form that we'll look at here in a second that has the clinical opiate withdrawal scale on it. Because, we all are concerned that if we just cut patients off these medications that we're going to throw them into withdrawal. So if you look at the COWS form and know those criteria, you can say, well, you're not in withdrawal now. How can I throw you in withdrawal by not refilling your prescription? And that's my standard statement. I just need to know what's in your body. I'm your doctor. Come on. This is the COWS form. There's a little scale. It's kind of hard to read over there. Basically, if your numbers come back under 5, you're not in withdrawal. Kind of keep those things in mind while you're assessing and talking to your patient. You'll see some patients come in for a sinus infection, and you spend in primary care anyway. You spend this time talking about their runny nose, and the visit's over, and it's, oh yeah, and I need my pain medicine refilled too, and I think that's what's going on. A little statement about urine. It's really hard to find clip art for urine, so I thought that would turn into urine pretty quick. And when I think about the creatinine, usually greater than 20, diluted specimens 2 to 20. If it comes back less than 2, it's not urine. So they'll say, well, it is urine. I say, well, no, it's not. It's less than 2. And if you're concerned about tampering, then you should go back in, get another witness sample, and send them both to the lab, get them both analyzed, and see if there's a difference if you're really interested. This is a slide that shows the time of opportunity with most medications. You can see most of it's 1 to 3 days. Notice that contact to THC is 0. So if THC is positive, they ingested it. It's not that they were at some house and some dude took a hit. They took it. Okay, so as far as this slide is a compilation of several different studies looking at urine drug screen results. And you can see the positive unexpected were positive things that were not there, and positive or unexpected negative are things that, no, I said that backwards. Positives were the things that were there that shouldn't have been, and the other are drugs that were unable to be recovered. And you can see 10 to 25% on most studies. So I think that you're going to expect, and I've seen that in my office, that frequently you're going to have abnormal urine drug tests, and you're going to have to come up with an orderly, reasonable plan on how to deal with those. Marijuana, I've heard speakers have various opinions on marijuana. A lot of marijuana is being smoked these days. The one viewpoint is that you have to be clean to get a prescription. The other is that it's not grounds for termination. In my office, I tell them that I'm going to retest them in 2 months, and if it's still positive, then I'm not going to be able to treat them. And it takes 30 days for a chronic marijuana user to clear the drug from their system. So I figure that 60 days works well beyond that, and that also gives them time to find a new doctor if they feel like they don't want to comply with my rules. Managing non-adherence, the first thought that I see from a lot of patients, based on what they tell me, is I was fired because of this. Well, I like to think of as non-adherence as an opportunity to improve care. Is this a sign of illness, whether it's addiction or pseudo-addiction? Is there, like we said earlier, some type of undiagnosed pathology? Are we just barking up the wrong tree with our treatment? Or is this some type of criminal activity with diversion? The non-adherent patients can be very problematic, especially in rural areas where you're there by yourself with 2 or 3 older ladies usually, or something like that, and some of these people can be young and aggressive, and the first question is, are you and your staff in danger? And then if you're not, then is the patient. And you need to think about the bipolar patients that Dr. Anthony talked about earlier. Opiates have some strong dopaminergic activity, and so a lot of these mentally unstable patients will try to use their pain medicine inappropriately to help get some relief. You need to identify that. Also be on the lookout for acute withdrawal, which if you use that COWS form or familiarize yourself with it, you can hopefully have a better handle on that. And then show sincere concern. And I don't mean just, obviously you want to show them that, but you want to be concerned. And I've noticed that has really diffused a lot of incidents over the years when you say, I'm really worried about you. What's wrong today? I mean, don't bow up with them. I mean, that just doesn't go that. It just doesn't work. But I've never had anybody want to fight with me when I told them I was worried about them. It's just disarming. Managing non-adherent patients, I tell them they're on probation, and we establish some criteria Sometimes I write their prescriptions for 1 week at a time. Always require frequent urine drug tests on those patients, especially if we're wanting to see some changes in behavior. I think you should consider, is this a dependency problem versus a pseudo-addiction, which I have another slide on that in a minute. And my partner and I are both trained in Suboxone management for opiate dependency. I think that's one of the best things I've ever done as far as the pain part of my practice goes. It's always been our understanding that with an addicted patient, you're only allowed to write a 3-day script and refer them on. If you're able to treat them with Suboxone, you can do something really within 48 hours for them. It's given me something that I can use to treat patients who are probably the biggest headache prior to doing that in my practice. It's like, oh my gosh, we've got this patient with no insurance, no resources, and a pain pill problem. What are we going to do? Well, you can treat them yourself if you go through that 8-hour course, and it's free. You can go to buprenorphine.com, and I think it's well worth the education. It's some of the best CME I've had. It's an online deal. You can do it at your own time or your own speed. There's referral for counseling and pain management. If your patient's not Blue Cross positive, this can be a real pain for your staff on trying to get them in for counseling. And then finally, if they go through all that and they're still not playing ball with you, then it's time for dismissal. Addiction versus pseudo-addiction. There are some long definitions, but to keep it short and on one slide, addiction's a chronic relapsing disorder with continued drug use in the face of known harm. And I'll tell patients, look, you've been misusing your medication, your liver enzymes are up, and you've had a car wreck. Okay, we need to stop this now, or else you're going to be an addict, because it's an addiction once you're going forward knowing that it's causing harm. I'm telling you, I'm your doctor, I'm telling you it's causing a problem. If you continue with this behavior, you're an addict. Do you want to consider yourself an addict? And they'll say no, and that'll give you an opportunity to change. Some of the psychologists in the room might disagree with my approach to that, but I found it's been effective in changing some behaviors. Pseudo-addiction is a iatrogenic misinterpretation of pain behaviors. I think that was first diagnosed in the 90s when they took a young gentleman who had some problems, who was showing some bad behavior, and he was treated with opiates, and those symptoms improved, and it was called pseudo-addiction from that point on. I think it was probably more common in the early 90s than it is now. I think when I graduated from residency, there was a lot of undertreatment. I remember going to a CME event where a pain doctor was talking about his patient who took 3,200 milligrams of morphine a day and did fine. I don't do that. But I think today, it's come back around to where maybe there really are too many pain pills being prescribed. And so probably only a 1 in 10% chance there's really pseudo-addiction these days from some of the studies that I've read. Opioid dependence, this is one of the, we have a form that mirrors this that we use in the Suboxone part of our practice. And basically, if you have 3 of those items, you meet criteria for opiate dependency. So I put that in a form in our Suboxone packet, and we had the patients fill out some detailed history, and we let them collect that data for us just in kind of a yes-no type format. Dr. Weineke talked a little bit about the ORT. At our office, we've incorporated that into the new patient questionnaire. It's only 5 questions, and patients seem like they answer it pretty accurately, and they're just in the habit of going through there. I'll put my surgeries down, my meds, and have you had any of these things? And you collect the data there, and I think that's different than asking them to fill out a form in the context of a pain prescription. And so you're either high, low, or medium, and so if you see that they're low, then that means that you have about a 90% chance that you're not going to have problems. And if they answer in the high score, then that means you have about a 90% chance that you are going to have problems. And so I saw a young gentleman. I'll say he's young. He was 40. That's close to my age. And he answered item 3 as his only yes. So he had 1 point, which put him in a low risk stratification. But when I urine drug tested him, he told me he was on nothing, and I tested him and he was on methadone. And so, 90% doesn't mean 100%. And I was asked to leave time for discussion at the end, and that includes my material. So thank you for having me.